Hi, thanks for tuning in to episode number 42 of the Doctor Podcast show, and I'm your host, Dr. Robert Seichert. Today we have a great guest, Dr. Isaac George. Dr. George is a cardiac or heart surgeon. He's the Associate Professor of Surgery and Medicine at Columbia University, one of the most prestigious institutions in New York and the country. He's also the Surgical Director of the Heart and Valve Center at Columbia and the Structural Heart Disease Center at Columbia. He's also the busiest cardiac or heart surgeon in New York, so he's incredibly experienced, has many years of experience doing various types of heart and cardiac surgeries. Thanks very much for taking the time, Isaac, to come today and speak to us about this topic that everybody's interested in. A lot of my patients, especially elderly patients, are telling me that they're having valve surgery or heart surgery, and they ask me for advice, and I go, I don't really know too much about that. I'm an eye doctor, so I appreciate you coming to the show. Can you tell us how many years of training and education it takes to become a heart surgeon like you are after 4 years of medical school? Tell us about how you did that.
It's too many years, actually. I wish it was less. And
that's what the neurosurgeon said when I interviewed him last week.
It's a common theme. And the common theme is also that you become very good and you're very, very high level at the time of your completion of training. And the training is important because it's an extensive, in-depth training, and it prepares you for independent practice for almost any situation. And these are situations that are important because they're life or death sometimes.
Right.
And so the better the training, the better the experience, the better the outcome, and obviously better for the patient. So the training is long. After medical school, which is 4 years, I did a general surgery residency. That training was 5 clinical years and 2 research years. The research time I did at Columbia in one of our laboratories, doing a lot of pharmacologic studies, large animal studies, still doing some operating. At the completion of those 7 years, I entered my cardiac surgery training, which is a specific fellowship. That fellowship is 2.5 years, 2 full clinical years, and then a half year of research again. That training has now actually changed. They've actually taken all of those 7 years and made it 6 years and just made it dedicated to cardiac, so it's probably a better experience nowadays. Nonetheless, 7.5 years. I did 6 months of specialized training doing LVADs and transplants. LVADs are specialized heart pumps for people who have heart failure, and heart transplant we know about. So at that time, I finished my training, and I was a little bit at a crossroads. I wasn't entirely sure if I wanted to do heart failure surgery, transplant, and I ended up taking a year where I did something totally different. I went into the cath lab. This was 2011, and this was just at the time that technology was changing. We were starting to do transcatheter valves. These are valve replacements through the leg. So there was an opportunity to spend time in our cath lab and learn this specifically. Classically, all of this kind of endovascular percutaneous training is done by interventional cardiologists, maybe vascular surgeons or specialists who just do that, and not open surgeons. They offered me a position to do that training and operate 1 day a week, but primarily do percutaneous training for valve replacements, valve repairs, as well as coronary stents. And so I took that opportunity. We had one prior graduate who did that training as well, and it turned out very well for him. So I took that opportunity. I spent a year in the cath lab doing something totally different. It's like relearning riding a bike. So it's a new experience. And then I finished my training in 2012. So I've been in practice now 11 years. And my practice is a hybrid, and people call me a hybrid. I'm a hybrid in almost every sense of the word. I do open surgery, I do catheter valve surgery, I try to mix everything together in the same procedure sometimes. Sometimes the best option is actually, a mix of some of these techniques. So my practice is hybrid. I take care of patients in that way, and I try to figure out what the best option is for them. It's a great practice because it allows me to do a lot of different things.
That's incredible. That's about 10 years of training, if my math is correct. Is that right?
That is technically, 10 and a half.
10 and a half. All right, my math was, sounds like you're ready to retire.
I feel like it,
You feel like it sometimes. You mentioned a couple of things there that I wanted to ask you about. Some of my patients sometimes don't know the difference between a cardiologist versus a cardiac surgeon. Could you just explain the differences between those two things?
Absolutely. So we are all heart doctors, and I wish medical training was different. I wish when we started out, the medical system had said, you are going to take care of people with neurologic diseases or with heart problems or with lung problems. We've devolved in some way, and we've said, look, you have a specific skill, and you're going to do that. So we lose sight of some of the bigger picture of things sometimes when we become so super specialized. We are cardiologists if we take care of the heart with medicines, or if we do catheter procedures, you're an interventional cardiologist, which is a subspecialty of cardiology. You're also a heart doctor if you're a cardiac surgeon. You're a different kind of heart doctor. It's under a surgical training pathway, which is very different from the start of medical school, as you know. And so we specialize in our hands in doing open surgery. And so the classic definition that separates a cardiologist from a surgeon is that one operates and one does not operate, or one does procedures non-operatively.
Right.
Fundamentally, though, I think the better classification is if we could be heart doctors and we use different skills. And that's one of the impetuses to do a training where you can learn both of those things.
Right. Now, you also mentioned interventional cardiologist and percutaneous cath. Can you explain what those terms are for people out there?
Absolutely. So a percutaneous approach is a non-surgical approach using wires that go through arteries or veins in your leg. And those wires and those veins and arteries connect your whole body. And so you can put wires into these vessels and access most parts of your body, specifically the heart, the lungs, the areas around the heart. And you can use those wires and these vessels as conduits to deliver things, stents, valves, other kinds of devices that may help your heart or your lungs or your brain or wherever it may be. Specifically, the heart is very vascular. It has a lot of vessels. The vessels provide blood to help your heart move, the muscles to grow and to be sustainable. They also provide access to the valves. In the heart, there's a chamber, there's 4 chambers that are filled with blood. And those blood chambers are a great way to get access to the heart without opening your chest.
So the percutaneous means you go in through a vein or an artery in the groin usually?
Correct.
And then since all the blood vessels are connected, you can pass that up into the heart.
That's exactly right. You can even go from a vein to an artery, and even in the heart, one side is more venous and the other is more arterial. You can actually go across the chambers of the heart to access either side of the heart.
That's pretty amazing, and that's interventional cardiology. Now, cardiac surgery, you're actually cutting the chest open, small incisions, or in the old days, large incisions, and actually accessing the heart directly, right?
Exactly. The reason people want to do surgery is because they want to use their hands. And
right.
You use your hands, you get into a space, and you're manipulating things with your hands. So the traditional open heart surgery used to be an incision from here to here.
Right.
And thank God, if you see people in the 60s and 70s who were early patients, they had scars that were literally almost above their belly button. Nowadays, we try to make that much smaller. It's about this big if we're opening the chest. But we do open the chest. Your sternum protects everything inside of your body.
That's the bone, the chest bone.
Your chest bone protects everything inside. It's a ideological or evolutionary mechanism to protect the body itself. There's a middle bone there called the sternum, and we open that with a saw. That opens full access to the heart, the 2 lungs as well. We also use smaller incisions on the right side of the chest and the left side of the chest, in between the ribs, and that actually allows us to make an entry point into the heart through some of the chambers, specifically to access the mitral valve, the tricuspid valve, and do surgery on those valves, as well as even the aortic valve nowadays.
Right. So you mentioned you did over 10 years of training, which is incredible. I only did 5 after medical school, so twice as long. And what inspired you to become a heart surgeon?
That's a great question as well. I'm not entirely sure. People ask me that. You know, I originally went into medical school thinking I wanted to do research. I was an engineer, an undergraduate. I was a
Really?
mechanical engineer.
Where did you do that?
I trained at MIT.
Really?
And so
That's quite a shift. Why did you switch from engineering at MIT to medical school?
it is a shift, but you know, mechanical is very physiologically related. There's a lot of ways that it's very similar to the heart, how the heart moves, how the heart flows, the fluid dynamics, even all the aspects of contraction and physiology of actual heart cells is very, you know, engineering related. And so we found actually in undergraduate, there are a lot of engineers that are doing a lot of really cool medical research. We have some of the top engineers, chemical engineers doing drug delivery, doing tissue regeneration, tissue engineering. And so it was a really exciting place to be because you saw how these engineers were interacting with actually physicians in the local area and doing some cutting edge stuff that, again, like a hybrid model, you can't do alone, you know, and I think the theme here is that a team really gets things done in a way that an individual can't. So I got exposed to engineering, I got exposed to research, I got exposed to medicine. My father was a physician, and so I had exposure from the clinical practice side. And I originally always wanted to do some kind of engineering related work, and I found that the medical side of it was also very interesting. So I thought, you know what, I'll go into medicine and do engineering type research and be a researcher, academician, and really focus on things like design, devices, whatever it may be. I went into medical school, I really enjoyed, you know, internal medicine.
Right.
And I thought, okay, this is my calling. It's a very intellectual field, and I just didn't do that well on my rotation. I just didn't do as well as I thought I should and I could have. And I said, look, I have to figure out what I'm going to do. And right after I did my internal medicine rotation, I did my surgical rotation, and it just seemed to click. It's one of those things, you know, you figured out that you match well. And that's what it was. I enjoyed it. I wanted to do more and more. I didn't want to go home. And everything that I loved about medicine, I found I could get with surgery, plus another side of it, maybe a little bit more of the engineering or the hands-on,
Right.
which somehow was more appealing. So I went into surgery, and I haven't regretted it one bit. It's really allowed me the opportunity to do a lot of different things: research, device design, new technology, innovation. There's a clinical practice that's very intuitive, but also very repetitive. And you find that you get into a groove and you get into a rhythm, and that suits me very well.
And you didn't go home for 10 and a half years.
That's right.
So that was perfect. Now, tell us what kinds of heart surgeries you do. And you're, again, one of the highest volume surgeons probably in the country and in New York State.
That is true. So I do open surgery. I probably do 150 to 200 open surgeries a year, and then I do a lot of transcatheter procedures. And so when you mix all of those together, those provide those numbers that are very high. And I have that opportunity because of the location that I'm at. The hospital that I'm at is one of the busiest in the world for specifically both of these kinds of procedures, open surgery as well as transcatheter valve procedures. So I'm a very busy operator, and I do procedures 4 to 5 days out of the week. I see patients 1 day a week, plus mixed in between cases. And the kinds of procedures I now focus on are really, primarily valve procedures. So aortic valve, mitral valve, tricuspid valve. There's one other valve, the pulmonic valve, that is rarely an issue in adults. It's very commonly an issue in pediatrics, so it's not that I'm ignoring it.
Right.
It's very well taken care of, but I mainly focus on the aortic, mitral, and tricuspid valve. So these kinds of procedures are open procedures from the front, mitral valve often from the side or even with a robot, a tricuspid valve from the side, sometimes from the front. Occasionally we'll have to do bypasses at the same time if they have concomitant other issues. And then outside of that, I have a whole practice doing transcatheter structural or percutaneous valves. Those can be replacements, those can be repairs. Those are all done through the leg or artery or vein. And so there's a growing discovery of how this has really changed medicine. And so my practice is a combination of both of those. And I've given up, and there's sacrifice, and I think it's important to note, the progression of this from my practice. Early on, I think I made the right decision, and it's always hard in hindsight to figure out if you did something correctly. I had the opportunity to be a busy open surgery, and I had the opportunity to say, look, I don't want to do surgery anymore. I just want to do structural valves and catheter valves. And I said no to both, and I said, look, I want to make sure I maintain this identity because it's important, because of the value that I get with both of these. And I think you lose a little bit of that if you go one way or the other. Probably could have made more money or made better, been more prominent in one of these fields in one way or the other. But I really gave up some surgery to do the catheter valves, and I gave up some catheter valves to do surgery.
So you're doing both.
And I've been very strict about that, and I think overall that's helped my practice.
Right. One thing I noticed in my patients years ago, if they needed a valve fixed, you had to replace it. You really couldn't fix it, and it required a large incision in the chest and then days or weeks in the hospital afterwards. You mentioned that now you put in valves transcatheter. Can you explain what that means and how it's different than cutting the chest open?
This is really one of the true revolutionary things that's happened in cardiac medicine over the last 50 years. It really has changed the lives of so many people. So I'll give you a little bit of history. In the 1990s, people had realized that in patients who have leaky valves, you can sometimes put a valve in the descending aorta, far away from the heart. That's a one-way valve, and it would prevent the disastrous consequences of leaky valves. Again, all the heart valves are meant to be one-way valves. If they leak or if they form calcium on them and they don't open, they become dysfunctional, and you concurrently afterwards go into heart failure, or you can even die. And so it's purely a structural problem. It's a mechanical problem. If something's not working because it's leaking or it's blocked, you have to fix it. It's like a plumber.
Right.
And people realized, look, if there's another way to do this without doing surgery, it's going to be through an artery or a vein. And so the concept of trying to use a metal stent to open up a valve that was blocked or to fix a valve that was leaking came about in the 90s in animals, and then was eventually tried in 2002. The first one was done in France by an interventional cardiologist who actually just recently died.
Oh.
And so, it's a tribute to his perseverance and dedication to the field that this has become such a big deal. His name is Alain Cribier. But regardless, 2002 was the first time this was done, and it was successful, and the patient did well. Since then, the trials have been performed in hundreds of thousands of patients across the world just in trial and study. It's been probably one of the most studied devices in the world, sequentially from patients that are very high risk, who have blocked valves, to intermediate risk, to low risk. And each one of these trials have been thousands of patients that have been randomized to one therapy, these catheter valve or surgery. And all these trials have shown that these catheter valves have performed very well, equal or maybe even sometimes better than surgery in the short term and now the intermediate term. So it's been approved for clinical use in the United States as well as Europe since 2011 for high-risk patients, and then finally for everybody in 2018. So we've treated, again, hundreds of thousands of patients. We do about 120 to 130,000 of these valves in the United States. It's now double the number of open surgical valves, and it's surpassed that because of its recovery. Patients go home the next day in general. Some patients go home the same day occasionally.
As opposed to being in the hospital for days or weeks after.
The stroke rate is lower. The valve performs very, very well. again, the recovery is just immensely, profoundly different.
So you're basically passing up a little valve through a catheter, through a blood vessel, and then you open it up inside the heart to where the defective valve used to be?
That's right. And so the way that we get it to stick in is that it locks into place on that calcium that's on the valve. And
So you're using the pathology as the platform for the new valve.
exactly. We pace the heart so the heart isn't squeezing, because if the heart is squeezing, it'll just eject the valve
Pop it out, right.
So we temporarily pace the heart just for 20, 30 seconds, and then we stop.
When you say pace, you actually stop the heart?
We stop the heart. We use a pacemaker that's, again, inserted through the leg. It's really remarkable. And what we found is that we've increased the number of patients that we've diagnosed and treated for aortic stenosis. There was a huge population of people that were in their 80s, their 90s, that were vibrant people that were always told, look, you can't survive surgery, you can't get surgery, or they've never wanted surgery.
Right.
And so we've changed that dynamic. We've changed that whole paradigm. And now it's really, it used to be everyone has to have surgery. Now it's, can they get TAVR? If they can't get TAVR, then let's do surgery.
That's the abbreviation for the surgery, TAVR, T-A-V-R.
Correct.
What does that stand for again?
Transcatheter aortic valve replacement. So it's really become revolutionary.
Now, how do you image the valve while you're doing this to make sure it goes in the right spot and stays put? How do you see inside the heart while you're doing this?
So there are two ways to do that. One is with fluoroscopy, which is basically an X-ray. So we put the patient on an X-ray table, and we have an X-ray above that we can move around in different projections. We give contrast, which is a solution injected into an artery or a vein that lights up under X-ray. So we can see the critical structures, position the valve in the right place, and deploy the valve, and then check and see if it's leaking, if it's working. The second way to do that is with echocardiography, which is a small ultrasound probe that we put on the side of the chest that we can see ultrasound images with.
Can you also pass an endoscope, like a little mini camera, into the blood vessel, into the heart to see what's going on?
It's a great question. We pass the ultrasound probe through a patient's esophagus into their stomach. The esophagus and stomach are located right behind the heart, and so you get very good pictures from the ultrasound probe to see the heart. You can't actually pass a probe into the blood vessel and see actual images. You can pass a probe into the blood vessel and see ultrasound images, and we call that ICE, intracardiac echocardiography. And we do that frequently, actually, for mitral and tricuspid valve procedures. But you can't see the actual image in the same way. One of the things that the ICE probe and the echo probe, especially through the throat, allows us to do is it reconstructs the image. So just what you see in the heart spatially gets reconstructed on the screen in 3 dimensions, and we can rotate that around and see everything. What's even more incredible is that image can actually be projected on a hologram. And so you can wear certain virtual reality glasses, and you can actually see and play with that image itself. Not necessarily in the heart, but outside, so you can see critical structures if there's difficult anatomy.
That's amazing. I interviewed a VR specialist, virtual reality, a few weeks ago, and it seems like maybe the Apple Vision Pro device, that's the new VR device, might be useful for your specialty. Just give it time for the software to develop.
I'm sure it will be.
That's amazing. And how many TAVR procedures do you do?
Our center does, between 500 and 600 a year. I used to do all of them because I was the only surgeon covering all of this. So I have a lot of experience.
So you're still not
this.
getting home?
No, but now I have a partner, and I do about 350 of these.
Wow, so you're very busy. That's amazing. What's the most challenging type of case that you do?
There are 2 classes of patients, and I can say this unequivocally because I've taken care of them in the last few weeks. The first patient is the radiation patient. These are patients who in the 1980s, if you get lymphoma, which is a blood cancer or a cancer of your immune system, that can be very dangerous, then you have to get rid of it. there are two ways to do that, either chemotherapy or radiation. Back in the 1980s, or 70s, 60s, even all the way before, the way to do that and the way to treat that was with whole body radiation, very, very strong radiation. So you undergo radiation beam therapy and they zap your whole body. And what happens as a result 10, 20, 30 years later is that you get severe heart disease, radiation heart disease. It affects other things. It affects your skin. You can get skin cancer, you can get cataracts, you can get esophagitis, stomach problems, you get other cancers, obviously. It treats the cancer of your immune system very well, but you get all of these after side effects, lung problems. Specifically in the heart, there's a couple of ways that you get damage. The heart doesn't squeeze as well. You can get constriction of the heart, so it just doesn't open or relax as well.
It gets stiff.
It gets very stiff. The tissues get very fragile. It's a situation where they're kind of tough, but they also fracture almost. The tissues are very fragile. And then last and most importantly, they get very severe coronary artery disease, so the arteries to your heart get very diseased, and the valves get damaged. They get calcified and immobile, and so they usually leak and they also don't open.
So kind of everything goes wrong years or decades later.
That's
so
correct.
How do you fix that?
So they oftentimes need surgery. A lot of the time they need surgery because it's multi-valve disease, and the calcium patterns and the pathology patterns are just not amenable to fixing it with a catheter. If we can fix it from a catheter, absolutely. That's usually our first line. But if not, then we have to operate. And those cases can be very challenging. The patients have a difficult recovery, and when they go well, and patients feel better. But they can be very challenging. Patients bleed, they have a higher risk of stroke, higher risk of complications, and they're technically not easy to do.
And they probably go for hours?
They go for hours. They can sometimes be very long, particularly if they're a reoperation, if they're older, they can be long cases. The second class of cases that are frequently sent to higher level centers or frequently sent away and not even offered surgery are patients with what we call MAC. Now, MAC stands for MAC, mitral annular calcium. This is an entity that's not entirely clear why we have it. We have it certainly more in the Western world than we do in Asia or even Europe. So we see it a lot. There's a lot of things like that, right? Obesity, diabetes.
Right.
Is it related to our diet? I don't know. I mean, it's not directly related to smoking that we can tell, and maybe there's some relationship with what we eat, but we clearly have a problem with it in the US, and we're seeing it more and more, and we're diagnosing it more. Calcium forms tremendously along the mitral valve annulus. The annulus is kind of a circle that supports the leaflets themselves. So this calcium just forms, and it becomes a very severe eroding calcium that forms into the muscle of the heart as well.
So it spreads into the heart muscle from the valve.
It does, and it's thick, it's big. It's not, you think of a leaflet, it's just like a thin structure. This MAC becomes, as thick as my two fingers sometimes, even more, and just encases. It's like a rock. And it can get to a point where if you operate, you can't pass a suture through it. You just physically cannot. You can remove MAC, but sometimes you get situations where you just can't remove all of that MAC. And so we've really tried to figure out ways to do this procedure where we can fix people, help people with keeping them alive. These operations, if you resect everything, can have, disastrous complications of bleeding and stroke. We've taken some of the catheter valves and tried to put them in, and sometimes they work from the leg, but a lot of times we have to do specific operations and specific techniques through an open operation or exposure to treat these patients. So we have a lot of experience at that at our center, but they are complex cases. They're difficult patients to manage. It's a difficult surgery. We have a specialized group of people who help us with these cases.
So it's a team effort.
It is a team effort.
Right, you need the right anesthesiologist, you need the assistants, nursing staff, radiologists, everybody.
And patients come to us. These are not cases where we go out and say, hey, do you have MAC? Let's fix this, even though you don't have symptoms. these are people that come to us, and I tell them, you have to tell me you want this done. Because it is a high-risk procedure, there are complications that can happen. When it goes well, people feel well, but we only want to do this when it needs to be done. So.
Right, but the alternative is they're eventually not going to do well if they don't have the surgery.
It is not only that, and that's what I try to tell people, because the alternative is actually something more grotesque. It's that you slowly die of a very terrible heart failure. Your lungs fill up, you can't breathe. And so if someone told you, look, you're going to die in 20 years, you're going to die at 80, I'll say, okay, fine, you know what? I don't wake up one morning, that's totally fine with me. I would sign on the dotted line, no problem. But it never really happens like that. And specifically with some of these kind of patients, the radiation patients, patients with lung disease, or these mitral valve stenosis patients, they slowly eke along. They slowly fill up with fluid in their lungs and they can't breathe more and more. They get swollen, edematous, they can't move. I mean, it's a really terrible
kind of don't have an option but to do this.
You know, the option ends up being have this terrible prolonged death, or have a major complication and you don't survive, but you gave it a shot. And a lot of them will take that second choice.
Right. How many valves can you replace at one time in a patient who doesn't have MAC but just has, let's say, mitral valve and aortic valve disease? Can you do both at the same time?
We can do all three, aortic,
three.
mitral, tricuspid, and we do that frequently. You know, the main part
How
of the
long
procedure.
does that take for you to do that?
You know, about 2 hours.
2 hours?
With the heart stopped. So we stop the heart. You know, again, with all of open heart surgery, we go on a bypass machine that takes the function of the heart and lung. We stop the heart. You know, we give a solution that lets those cells not move and the heart doesn't move, and then we remove all the blood from the area that we're operating. And we have, you know, probably up to 4 to 5 hours when the heart can be stopped, that you can do everything that you need to do. Occasionally, you need more time, and that's a big problem. But most things you can get done in
So for
4
the
hours.
people out there in the audience, there's a machine that you connect the body to that takes the place of the heart during the time of the surgery.
That's correct.
Right. So they're not really dead or dying. They're just in a temporary state where their heart is not moving.
Correct.
Do you also cool the heart during that?
We do. We do.
And that keeps the cells living while there's
That's right. You're using less energy when you're cooled down. And that's one of the ways that we protect the body, we protect the brain, we protect the heart. You know, there's reports of young people in Norway that fall under a lake, and then 45 minutes they're revived and they're totally fine.
Yeah, it's amazing.
And so similar concept, cool down and protect.
Right. What are the latest new technological things that are coming out? You mentioned you were in mechanical engineering, MIT. What's the latest and greatest things coming up in the future?
We have a couple things that are specific to heart valve disease. A couple of them are device related, so some of these are repairing things that we typically always used to have to replace. So one of the things that as a concept that we are trying to do is take the things that we do in surgery and mimic them in catheters. So that's cutting leaflets, that's cutting out leaflets, that's cutting parts of the heart, parts of muscle. And now we've been able to do that. People have developed techniques where you can take wires and pass current through them and cut them in the body, in blood. And you give a saline solution to protect that current, and a very small portion of a wire is exposed and can cut tissue and allows us to do things that we were unable to do before. We have new techniques to anchor valves, anchor bands, rings in place. We have new materials that potentially will come out that could, again, change another next generation of revolution, where we have polymers that can actually become leaflets and be leaflets. And if that's the case, then the animal tissue that we're using for valves, which wears out after 10, 15 years, these polymers maybe could last you your whole lifetime. And if you did that, then you get a valve replaced, repaired, whatever it may be, and maybe it lasts you your whole life rather than worrying about having to replace it again. We have tissue engineered bypass grafts, so you implant a graft, instead of using arteries and veins for bypasses, sometimes you can use tissue engineered grafts. And what those grafts do is they allow your own cells to populate and become a new blood vessel.
Really?
We've been doing that in clinical trials now, and I would expect in 4 or 5 years' time that we'll be using that in humans as a full commercial product at some point. So some really, really amazing stuff. I'm not even going into the pharmacology. The drugs that we use now are much better, and we can even avoid getting people into the operating room altogether. We have all sorts of digital monitoring devices, things that wirelessly connect to sensors, phones that will track and monitor what's going on inside your heart and tell you a month before you get sick or a week before you get sick, you need to take more medicine. You need to go see a doctor. You need to get this figured out. You're going into heart failure. So that revolution from the digital information technology side is here, and it's coming, hard and heavy. So we're going to see some really interesting things on that end.
Right. Now, I know for decades they've been trying to create an artificial heart made out of plastic or metal. Where are we with that? I don't think they've been successful up to now.
It's a tough road, and you can imagine the issues with biocompatibility are the main thing. So in the same way that animal tissues reject or that they get old, when you take polymers, when you take plastics, when you take metals, they interact with the body and people form clot around them, and these pumps are so invasive right now that people still have complications such as stroke, bleeding. And so we are still struggling with that. They've gotten better. They've gotten smaller. We're seeing smaller and smaller ways to implant these pumps, and entirely replacing the heart may not be necessary. We're seeing that we can get away with using less flow or less support, and that's been okay. We can take pumps out for certain people after 5 days or a week or even 2 or 3 weeks. So some of these temporary partial pumps may be useful. I think the other technological and scientific advance that we're going to see soon is a real jump in transplant. And I'm sure you're going to ask me about the transplant field.
Right. I was just about to ask you, what about heart transplants? They've been doing that since several decades. How's that working out?
Transplants are amazing. Transplants are really the gold standard for treating heart failure when you're really sick. And I don't think we'll ever get away from heart transplant. It is a truly life-giving procedure and satisfying, by the way, in a way that cannot be replicated. I think there are a few things in medicine that are as amazing as a heart transplant. Putting a heart in, taking a clamp off, and watching it beat for the first time. I mean, childbirth, but those things, they're like going to the moon and walking on the moon. So that will always be there. It's a great procedure for people. We're trying to expand that out so that more people can get it. Using new animal tissue models. You've heard a lot about animals, pigs, that have been genetically modified on certain medications to suppress certain genes. Expensive, laborious, scientifically in-depth. Hopefully we'll get to the point where that can be more widespread. Even
I think there was a patient done at University of Maryland, but
University of Maryland for the heart. That's
right.
correct.
They modified a pig heart so that the the human's immune system wouldn't attack it.
Exactly. And these pigs were made specifically for this gentleman. They were grown specifically with the genetic profile. So I hope we can get to the point where that can work better and the drugs are not as expensive. Clearly, pigs or other animals are able to be mass produced, and if that helps us, I think that would be a great thing. We've also been exploring partial heart transplants. So let's say the left side of your heart is not working, but the right side is working. Maybe you don't need all parts of a heart. Maybe if one of your valves or part of your heart is not working, what people have been doing now is transplanting part of hearts into people, and with very good success because you can actually not have to give as many drugs. And that's particularly relevant in little kids where tissues have to grow. And a heart transplant will grow, but if you can avoid removing all of the heart, especially if part of the heart is good, then you may be able to get away with that.
So you can transplant just a left ventricle? Is that what you're saying?
Not specifically, but things like the aorta, the aortic
Oh.
root, the aortic valve, if those are damaged beyond, using, then you may be able to take a functional aortic valve from somebody else and transplant that, or the valve tissue itself. And the valve tissue will then grow, because problems with, a heart that is too small, hearts in general will grow, but not all of them will. And if you can lower the immune system and the drugs that you need for that, then maybe that's a big advantage.
Right, that's pediatric. You mentioned that you did some training in heart transplants, but do you do that currently, or?
I don't. I did that for a few years. It's a very demanding field and very specialized, again, and I had to make a decision when things were growing.
Right. Can't
what
do
to decide.
everything.
So
But it's done at Columbia.
it
right?
is done at Columbia.
I think it's one of the top centers for heart
It
transplants.
is an absolutely wonderful group. They've been doing it really since the early 60s. We did the first pediatric heart transplant in the country, and we've had a long history of transplant and solid organ transplant. So
That's great.
you can basically go in any day, night, into the OR at Columbia, and someone's getting a transplant. That's the saying.
Really, that many? Wow, that's awesome.
You have heart, lungs, pancreas, kidneys, liver,
And corneal transplants too. Right, we do those too. The valves that you're putting in, the transcatheter approach, what are they made out of? What kind of valves are they?
They're made out of metal. The metal is either nitinol or cobalt chromium, so they're all nickel-based alloys.
Nickel. There's no allergic reactions to that, because nickel is very allergenic.
Well, they're nickel-based. Meaning they have very small amounts of nickel, but they're primarily either cobalt chromium or nitinol. But yes, if you have a nickel allergy, that's a problem. That's a big problem, and you're not going to be able to get a catheter.
So you don't use pig valves or other animal valves for your procedures?
So the leaflets are made out of either cow or pig valves. And so the leaflets are sewn onto that metal mesh frame.
And there are companies that manufacture this, and so you order it based on the size and what you need? Is that how it works?
That's pretty much how it works. There are a few tissue processing centers, and they actually manufacture and develop the tissue for a lot of the companies, and then they sell them. So the valve companies themselves are usually not in the tissue processing business. It's just too much to do and manage which stock of animal, where it's coming from, all of that. That's a big business, and that's not easy to do.
So the tissue companies get together with the metal valve companies, they put it together, and then they
It's
send
sold to the valve companies, and then it's manufactured. A lot of times, the actual tissue has to be sewn onto the metal frame, and they're very small sutures. It's a very precise, detailed, process.
Is that done manually by hand, or are there machines that do that?
It is done by hand
By hand.
very skilled people that just do that
That's
day
ama-
after day after day. They have a microscope and they sit and they sew. It's an amazing thing to see the workroom for people sewing this.
And then they have to sterilize it.
To sterilize it, they do quality control. They inspect for any defects. They do electron microscopy to check the quality of all of this. So pretty intense.
That's pretty amazing. The coronary artery bypass surgery, do you do that surgery as well?
I do. I do about 10% of that in my practice. It's, again, a great operation for people. No one wants CABG. You're always the last person in the room because they've talked to somebody, they can't get stents, or they have such diffuse disease, or the anatomy is such that they're best served with CABG. And so CABG is coronary artery bypass. And so you walk in the room and you say, hey, I'm the surgeon. Unfortunately, you're going to need a bypass operation, and nobody wants this, but we'll get you through this, we'll get you home, you'll feel better, and hopefully this is the last procedure you'll need in your lifetime. One of the things that I tell people is, and same thing with surgery, this is an opportunity to take time off, to recover, to get healthy, to establish healthy lifestyle habits, If you're someone who didn't have good dietary habits, then now's the time to restart. We never want disease to happen again, and so I tell them that it's very important to have a strict, lifestyle modification. Stop smoking, reduce the drinking, sleep well, cut down your stress, exercise daily. Very basic stuff, but actually becomes very hard to do in daily life. And I myself am an example of that. It's very hard to keep up with all of those things. You have
Right.
so many stresses. You're hungry. You know you're not going to eat for another few hours, and so there's something there that you can eat that's probably not good for you, but you do
Right.
it. And so those are hard, and people have to really get in their head that they have to change their whole life. It's not just getting a procedure, it's changing your whole life. So it is a life-changing thing
Right.
that you get.
Who has those? People who can't have stents because their arteries are just too clogged up at this point?
Well, we have a better understanding of who's better for stents and who's better for surgery now. We've done a lot of trials. There's been a lot of back and forth, and you can read
Right.
in
It's been debated.
in the articles and newspaper, who's getting what and what's best for you. But again, they're complementary. They're people who are good for bypass surgery. There are people that are good for stents, and then there's a lot of people that are good for both, and they pick and choose. There are advantages to surgery. Usually there's, the general rule is the more invasive it is, the better performance of the index procedure it is. So bypass grafts last longer. There's some information and data to suggest that in certain patients it also makes you live longer. But in a lot of patients, stents and surgery are both reasonable options. The downside of stents is that you're in general going to have more stents put in at some point or have a reintervention. That time period has been anywhere from 5 to 8 years. Sometimes it's more, sometimes it's less. So it really depends on the patient's preference, with the acceptance that they understand that they may need another procedure. They may need surgery later. Sometimes people pick stents because they want to put off surgery. Some people say, I want to get it all fixed right now, and that's it.
Right.
And then there's certain populations where it's clearly better to do surgery. And we tell them, look, you should get surgery. This will make you live a lot longer. On the flip side, there's some people that are just too high risk for surgery, and we do stents. Right. And maybe their anatomy isn't perfect, but we accept an imperfect result.
Right. So if you have stents and then you keep your cholesterol super low, you stay on aspirin, you keep your blood pressure good, you start colchicine, which is a new thing, they still get clogged up eventually if you do all those modifications?
You have a lower chance. And actually, interestingly, within the last year, there were some study results that are pretty astounding. There are a different class of medications to control the cholesterol that control lipoprotein A and even control other kinds of cholesterol that are once a year, an injection 6 months out of the year, different ways to take it that are much better tolerated, or different classes of drugs that are really, really effective. So we're going to see a new era where the aggressive cholesterol, out of control damage will be reduced as these drugs become more and more common. Will it remove all of it together? I don't think so. I mean, I think there's a proportion of it that's dietary, there's a portion of it that's biologic, genetic,
right.
And then there's a portion of it that's just environmental, that we eat processed foods, we eat foods that are either not good for us, and we continue to do so, and those interact in our body in ways that we can't remove with just a drug.
Right. We also had about a month ago, I interviewed somebody who specializes in plastics contamination, and there's good data that the microplastics and nanoplastics that we're exposed to from drinking from water bottles, things like that, may be causing an increased risk of heart disease, and who knows, maybe those the MAC patients might have plastics depositing in their valves, and then the calcium attaches to that.
I mean, that's a great thought. You should go do some research. I mean, you're right on.
Is it too late for me to do a cardiac surgery residency and fellowship for 10 years? I could train under you.
Well, it's interesting that you say that, because that MAC theory, maybe it may come to fruition or not, but Actually, some researchers in Italy, I don't know if you talked about this study that came out recently. There was a group that looked at carotid artery plaque. These are patients who have blockages in the arteries in their neck. They get surgery for it, and they took those plaques out. Plaque is basically calcium and debris that forms, the cholesterol type debris that forms, and they took that out, and that's part of the surgery, to open that vessel up. And when they looked at those debris and that plaque and that calcium, and they found a high percentage of nanoplastics, not necessarily microplastics, but
there you
nanoplastics. So really, it was in the New England Journal of Medicine. It was mind-blowing, and it really goes to show that this is not something that we just eat. This is not water that we drink from a water bottle. This is so small that it's getting into our bloodstream. It is in our bloodstream.
Right. It's everywhere, and certain people may react to it immunologically and develop calcium or other abnormalities. There's some debate also in the literature about whether maximal medical therapy is as good as stents or CABG. What's your take on that? Do you believe that?
You know, that's a really tough question, and I don't know if I entirely have an answer to it, but I think the trend has now shifted, and whereas we used to say, look, everyone should just get some invasive therapy, we now have a very high value for medical therapy, and that's true for the valve disease, where we try to optimize patients with medicines, and now that's crossed over into that coronary artery disease. And we understand the value of controlling your diabetes, controlling your blood pressure, really being aggressive with cholesterol. And that can mitigate and reverse is a tough term to say, but it will certainly halt the progression of disease and keep people stable. So if people are stable and you find incidental severe disease, you can probably keep them as incidental if they maintain that. So the bar to intervene has become higher, meaning you really need to have symptoms, you need to have aggressive anatomy, or else you may not necessarily benefit when you compare it to aggressive medical therapy. That being said, again, how many of us in the Western world can really maintain aggressive medical therapy? It's not easy to do. Who can really eat, veggie burgers every day or eat salad every day? And so I think the challenge has been, how do you really maintain that medical regimen?
We have to change our entire culture, which is not easy.
Mm-hmm.
What advice would you give to medical students nowadays if they're interested in becoming cardiac surgeons? What do you tell them?
I tell them, make sure you love what you do, and it will always come out in what you do. You should have your passion. You should follow your interest, even if it's not what other people tell you that you should do or what you think you're good at. You should do what you're good at. And the best option is that you're passionate about something and you're also good at it. And those people become great leaders. And so I tell people, look, really do what you want to do and don't let anyone get in your way. If it's cardiac surgery, go ahead and do it. You should never not try. You should always try to do it. And hopefully you're good at it and you'll become good at it and become an expert. And I hope people become an expert in some small part of what they do, right? I think that's when you really become a contributor to science.
Right. If you enjoy it and you're good at it, there's no better combination than that.
Cardiac surgery is demanding. You give up a lot. You give up, the ability to do other things. Maybe you're not as in shape as your friend who's running a marathon. So you give up. The time constraint is large. You give up. Your family has to face some of that and bear some of that. During the weekdays, do you see your kids as much as other people? No. But you have to balance that, and you have to try on the weekends to say, all right, I'm not going to do work unless I have to. Or you figure out what's right for you. I'm not going to tell anybody what's right, but you figure out what's right for you. But you just have to understand going in from the start. You don't want to be surprised that, oh, this is a lot of work, and this is a really life-changing decision to go in because it's consuming. So I tell people, if there's anything else that you like just as much as cardiac surgery, then you should do it, because it's probably going to be an easier path and you'll get the same enjoyment and have more time. If there's nothing else that you want to do other than cardiac surgery, then the choice is made.
Well, this has been incredibly informative and educational for me, and I'm sure for the people watching out there. I really appreciate taking your time from your busy, hectic life and work to join us today and explain all this. We all really appreciate it.
Thank you very much for having me.
It's been a pleasure.
Absolutely.
Thanks very much.